Thank you. Thank you, Dr. Cohn and Hoag, for having me. It's a pleasure to be here. My conflict of interest slide, it's for support for education. And so I'll just have a quick couple of slides on background, give my opinion on how the HPB specialist handles the call, and also talk about how to stage the repair, how to actually perform the repair with a focus on early repairs. And then if I have time, patient outcomes. We've all been in this situation, the difficult gallbladder, or even suspected bile duct injury. Please stop, get additional imaging, call a friend. And as I was putting this talk together, I was wondering how relevant is this issue today? You know, our surgical landscape's changing. So I searched bile duct injury in Ovid and got this graph. So the first laparoscopic chole was done in the mid-'80s, and there was an inflection. And then lo and behold, the first robotic chole was done in the mid-'90s, and there's another inflection here in references. Is this real or not real? Maybe it is real. In the last session, this paper was presented, but it's basically over 10 years, there was a 37-fold increase in the use of robotic-assisted technique for choles and a 3 times higher rate of BDI in robotic choles compared to laparoscopic. So I think it is real. This is happening. It will happen to most of us in our practice at least once. And whenever I think I've had a bile duct injury, which was just a couple weeks ago, it wasn't, but I still throw up in my mouth a little bit. This is very disturbing. And we, the specialists taking your call know this, and we have grace, and we're going to listen and not judge. We know that it could easily be us in the situation. And if you call during your procedure, we can guide you. I've talked surgeons into, yes, no, please do a cholangiogram before you close. No, you don't have to leave the patient intubated. Please leave drains and mark where the injury is with a stitch. All of these things are very, very helpful. And then, of course, communicate, both, about the patient, with the patient and their family. And I also usually guide the provider in terms of next steps there as well. So I'm going to move forward a little bit. The next step is going to be assessing the injury. So when you're in the OR at the time of injury, this is the best place and time to appreciate it. And getting IOC is essential, and there are other adjuncts that maybe you have access to. This was a recent referral to me. This was the intraoperative cholangiogram at the time of injury, that one image. And then he had a good friend that could do ERCPs that popped into the OR and got this image as well. So clearly there's loss of the bile duct, and maybe the cholangiocatheter is higher in the hepatic duct, and that explains the cholangiogram. So step 2, the patient's now been transferred. Now what kind of imaging do we need to assess the injury and the patient? So contrast CT imaging is essential, both to appreciate if there's a concurrent vascular injury, but also if there's undrained biloma or abscess. And then MRCP or ERCP, probably not both, to delineate biliary anatomy, and PTC, again, if there's no bile leak, but biliary obstruction, that's often helpful. So when do you need to delay your repair? Well, there's a few indications where you'd want to not rush to the OR for repair if you can't do it at the time of the injury. If there's an undrained biloma or abscess, concurrent vascular injury. If the referring physician's already converted to open, you might want to delay. And also if it's greater than 7 days from the injury, or if the patient's septic or unwell. So in this recent study, they divided their patients into red, yellow, and green zones, and only the green zone patients, those who didn't have abscesses or sepsis or organ failure, went straight to the operating room. And then in terms of delayed surgeries, they only went for their delayed repair when they were categorized as green. So again, if you can identify this intra-op and there's an HPB surgeon available, that's the best time to perform the repair. And then they further divided their group into with and without leaks in terms of how and when to intervene. And this is another algorithm for determining, next steps after bile duct injury. So drain and refer if you can't fix it yourself or you don't have an HPB specialist. And then if it's minor or major, that kind of determines the next steps in the repair. So at the time of repair in the OR, fixing your bile duct injury, IOC again is essential through whatever orifice you can find, just to understand the entire biliary anatomy, concurrent with ultrasound in every case to again look at biliary anatomy and also vascular injury. And photos, ICG can also be helpful. So when, how do we repair? Well, some bile duct injuries are actually pretty minor, and you can clip them, direct suture maybe, or use a T-tube. So for Strasbourg A, often if you can suture, clip, and drain, if it happens, it's a minor duct that is, doesn't really need a bypass. For the Strasbourg B, they don't have bile leaking, so they're rarely identified at the time of the operation. And if they're symptomatic, may need a hepaticojejunostomy or liver resection. So for the Strasbourg C injuries, sometimes you can do nothing, leave a drain, low volume leak, it'll heal on its own. Sometimes you need to ligate it or do a bigger procedure to manage it definitively. And then I love this paper. This is how I do my T-tubes. It's a technical paper that just explains cutting most of the transverse wall away, helps to decrease the damage to the bile duct when it's inserted. It makes it easier to remove, and it works just fine. So yeah, for Strasbourg D injuries, if the injury is less than 50% of the circumference of the duct, then you can leave a T-tube either through or nearby and repair it, and hepaticojejunostomy or other biliary enteric anastomosis if it's larger or if the injury was due to heat. And then these are the transected duct injuries. These do need a bilioenteric anastomosis. And whether you repair them open or lap, I think that comes down to the expertise of the HPB surgeon. These are some techniques for when the injury is very high, the Hep-Quinard approach, where you can extend the left hepatic duct, increase the size of your anastomosis, and also either resecting or retracting segment 4B to see higher up in the hilum. The only thing I would say about how to approach the repair is feel comfortable that you can do it safely, that there's a high rate of medical legal things that happen with these cases, so you really just want to repair it correctly, however you're able to. And so, okay, so I think this is an important slide in terms of outcomes for repair. Really, the only thing we can do differently to affect the rate of anastomosis, anastomotic stricture, is to avoid a post-op bile leak. So other things we don't really have control over. And then timing of recognition, again, is key. So patients who have bile duct injury have lower overall survival, but this is doubled when there's a delay in diagnosis of the bile duct injury. And actually, if you fix them perioperatively, then the survival rates are equivalent with patients that had an uneventful cholecystectomy. So I think with that, I'll end to try and save some time. Thank you.